in terms of some housekeeping. So I'm Rachel Claydon, a GP with Mater Refugee Complex Care Clinic, which is a service where we see people in asylum without Medicare. I'm also the GP Fellow for the Refugee Health Network of Queensland. And for those of you who are not familiar with the networks, we're a statewide network and we work sort of across health sectors and other sectors to try and achieve the best health outcomes and health and wellbeing for people from refugee background. I'd like to say a couple of thank yous for tonight. So our night tonight certainly would not be possible without the Brisbane North and South PHN and their support and their funding for this evening and lots of our education events. Also to the Tzu Chi Foundation for again hosting us in this beautiful space, beautiful food and the warm hospitality. I do have a few of those particular things to tell you regarding toilets, etc. So toilets are outside to your right if you need the toilet. Fire exits, I think the exit is here and to the side. Hopefully we won't need them. Also just to let you know that this evening is going to be recorded. If anyone is not comfortable with that, please let us know. Maybe let Ali know at the front. So I have some technology issues. Feel free to jump up and grab some more food in the meantime. So tonight we've got quite a few speakers for the evening, so we'll try and sort of move through at a reasonable pace. We'll save questions generally for the end, but I know that Najma from Multicultural Australia has to leave a bit early for a prior engagement. But to start tonight, I really just wanted to provide an overview for you all around what we talk about when we're talking about Refugee Health Journey, a little bit of context on the global situation and Australia's humanitarian program, and also touch on some of the health assessments that occur offshore for people, and then recommendations onshore. And I realise that a lot of you have been working in this space for a long time, so some of this information you'll know, but we also know we've got some new GPs and new healthcare providers tonight, so we'll sort of go back to the basics, so to speak. So when we talk about the Refugee Health Journey, it's good to sort of have a shared understanding of what we're referring to. So we're really talking about that full journey that people need to take when they're starting with that decision and that need to flee or need to leave their home and get to safety. So that journey can involve travelling across many different countries. It can involve for some people a prolonged period of time in a refugee camp or even a detention facility. And then that step of seeking asylum in another country and applying for a protection visa to be resettled somewhere else. So the process for people going through this offshore, and I know Najma will touch on this a little bit more, but people really need to prove or be granted refugee status to then enable them to be granted a protection visa for another country, to settle in another country. And sometimes this can take many years for people to go through this journey. And so we know obviously this can have significant impacts on health and significant trauma in that process. So just some global information. This is the UNHCR statistics that you can get online. And we know we can see for ourselves every time we put the news on some of the horrendous things occurring across the world. And these numbers of people being displaced from their homes has been going up and up and up, as you can see from the graph. Australia has a commitment, and Australia is a signatory to the United Nations Refugee Convention. And so Australia will settle and provide that humanitarian settlement and has a commitment to do that. At the moment, Australia settles around 20,000 people per year. In terms of that settlement, I think it's helpful for us to understand, and particularly as healthcare providers, we can see people in different phases of this journey, or people that have settled coming through different pathways. So Australia has the offshore humanitarian pathway, so that's where people will be granted a protection visa offshore. And then we also have people can apply for a protection visa and seek asylum onshore. So, people will come to Australia, apply for that protection visa and then go through the process of assessment onshore. We won't talk too much to that tonight, but just to know that at the moment there's probably around 3,000 people, although it's difficult to get numbers, of people who are seeking asylum onshore. They don't always have access to Medicare, but I did want to draw everyone's attention to the Queensland Health Directive, which enables people seeking asylum to access care in Queensland health facilities. Most of our focus tonight will be around people coming through the humanitarian settlement program. And so people that are granted a visa offshore through this program, when they arrive, will have access to settlement service support. And Najma from Multicultural Australia will talk to that tonight. And they will also be supported by the Refugee Health nurses. Temperamental clicker. Okay, and just to, thank you. And just to let you know that across Queensland, we have 5 settlement areas, and there are Refugee Health Service, nurse-led Refugee Health Services in each of those areas. And tonight, the nurses from Metro South, Logan Refugee Health Service will also talk about their role. So in terms of thinking about the health risks of the refugee journey, and this is what guides us into thinking about what assessments are needed, I think of what some of those would be by thinking about the journey that some people may need to take. Sorry. Geez, everyone. But I just wanted to draw your attention to some of these. I mean, a lot of them you can read, but it does depend on people's journey. And as we said before, some people will spend long amounts of time in camps or have traversed a number of countries to get to that final destination of seeking asylum. I think it's important also to realise that some people have come from places where there are really highly functional health systems, but for reasons of war or whatever has happened, their access to care has been interrupted. And so we do often see people who've had previously quite good medical care, but for whatever that reason is, that care has stopped. So we will often see when people arrive sometimes complex conditions or conditions that have not had treatment for some time. Obviously as well, nutritional deficiencies, trauma and trauma-related sequelae. So the recommendation from the UNHCR is that everybody has a comprehensive health assessment soon after arrival, ideally within a month. In thinking about that health assessment, I think it's important for us and the clinicians with us tonight to understand what happens offshore and what some of the medical checks are offshore. So in terms of the offshore assessment, all permanent entrants to Australia have a visa medical exam. And so the visa medical exam is conducted up to 12 months, sometimes even longer, before someone arrives in Australia. So there can be that delay. So it's really important, I think, that we realise that, and that a lot of the things we need to recheck and be mindful of. One of the major things in that visa medical exam is to identify if anyone has TB. If they have TB, it's treated, and the process is halted, that whole visa process, until that's treated. In that medical exam, it also includes screening. And so these is by Australian guidelines, panel doctor guidelines. There have been a couple of changes over the last couple of years that you might be aware of. Now that everyone over 15 will have a renal function and will also have hepatitis B and hepatitis C testing. So, and if somebody tests positive for a bloodborne virus, it doesn't mean they can't come into the country. Same with any significant health condition. All humanitarian entrants have a health waiver. So we will see people arriving with disability and illness. But people will have to sign a health undertaking, so meaning that when they come into the country, say they've had a hepatitis C or test positive offshore, that they will follow that up with a healthcare provider onshore. There are some pathways through public health for HIV. There's some pathways being established for Hep B and C. But I would reiterate, as GPs, we're the primary care provider, so it's up to us to check that people have access to appropriate care and had follow-up and not lost to the system. And if anyone isn't sure where people are at with that, you can certainly reach out to the Refugee Health nurses. And then people will also have a voluntary departure health check, which is usually around 72 hours before flying to Australia. And again, this is voluntary. It does involve sometimes some treatment, some parasite medication and things like that, and some immunisations. But again, it varies very much to where people have come from. So, and the refugee health nurses can share that with you in your practices. We would still recommend, so if someone has had offshore treatment, we would still recommend screening and treatment onshore. We can't always be certain how effectively it was taken, how effectively it was given, if the full doses were given. And this information is uploaded to the Department of Home Affairs Immigration Health Assessment Portal called HAPLIGHT. And as a GP, you can apply for access to HAPLIGHT. It's probably not really worth your while unless you're seeing a lot of new arrivals. Generally, for most people, the refugee health nurses will provide you with the information you need. But I know Debs, who's speaking later, sees a lot of new arrivals and does find access to this really helpful. So if we think about that health assessment post-arrival, really sorry, I'm not doing well with the controller tonight. So it is recommended that everyone post-arrival has a full, comprehensive medical assessment. And so ideally within a month, it's not always possible within a month post-arrival, but that's the ideal. And it's a full medical assessment, full examination, including migration journey, to have an understanding of where people have travelled, what we might need to look for in screening. And it also includes planning for screening, management plan, giving a copy of it to the patient so they have that information. And part of that can be completed, the refugee health nurses will often have done an assessment beforehand, so that can be included as part of your assessment, or the practice nurses in your practice can also work with doing this assessment. What I would say is that this often takes, what should take really a few visits. And it's not just about the screening. And I borrow that from my colleague, Margaret Kay, who's the Brisbane South PHN clinical lead, who always reiterates, it's not about the screening only. And I think sometimes as GPs, we worry about the screening or missing the screening. Very good resources to guide us what to do. But it really is more about that comprehensive health assessment, building trust, building that, relationship for that longevity and that GP-patient relationship. I just thought I would put up there to remind everyone about a full examination. I think it's probably rare that we really do a top-to-toe examination for people in practice, but just remembering things like checking skin, checking scalp, if somebody has wounds. I've also put up there, genitalia exam and screening. That may not be indicated. It's certainly not something I would usually ever do first visit, and being mindful that people have often experienced trauma, and it can take quite some time to really explain, like cervical screening and those type of examinations. In terms of the screening, so as I said, really good resources. So the Refugee Health Practice Guide is available online. A lot of you probably already accessed this. It's about to be updated, but the guidelines in there at the moment are what we would follow in our practice. We won't dive deeply into those tonight, but if anyone has any further questions or you want some more information about this, feel free to reach out to me at the network or the PHN clinical leads. A couple of things I did want to reiterate, and I know Dr. Debs, I think you're going to talk to this as well, is that in the sort of longer term, just remembering that often people are under-screened in terms of the general preventative screening, so mammograms, cervical screening, bowel screening. And I think there's a lot of reasons for that. Sometimes as GPs, maybe we're just not thinking of it because there's so much else and sometimes other complexity going on. But also people will have often come from health systems or cultures where preventative care isn't such a thing. It's not even done. And, you know, the bowel screening kit comes in the mail. No one knows what to do with it. So really important that we're mindful of that. Also, catch-up vaccines for adults often gets missed. I think we remember the kids really well, but all humanitarian entrants, adults, can also get free catch-up vaccination. So, and just to remind everybody that when you're doing a refugee health assessment, a comprehensive health assessment in your general practice, that there is a Medicare item number for that assessment. And part of that is obviously that, you know, the requirements that you will be that person's ongoing GP and that you provide them with a copy or offer them a copy of that assessment. I won't talk to this too much because I know Faiza and Rahim will speak to this, but just bearing in mind that the refugee health journey doesn't stop when people arrive to us. So that journey is ongoing when people settle and we start to see people as our patients in practice. And certainly there are barriers to people being able to receive quality care. And a lot of those barriers are things related to the bigger system, inflexible system, not responsive systems, but there are certainly things that we can be aware of in our practices to address those. And I know Rahim and Faiza will talk more to that. What I did want to just talk to for a couple of minutes is around having a safe place for people to see you as a GP, so when we talk about trauma-informed care. But bearing in mind, people don't flee their countries, flee their homes, unless there's a very good reason, and that's usually involving trauma in that journey. So I think, as I spoke before, take time to build that trust. We don't have to rush in necessarily and do the cervical screening and all of those things straight up. We can take time to talk that through. Also be mindful that that settlement period that Najma will speak to, it's a busy period and people have sort of been surviving and then trying to settle and enroll in school and study and all of those things. So it's often not until some time later that we can see people's mental health might deteriorate or the effects of what they've been through come to the surface. So just being mindful of that, and you know, if your patient's having trouble sleeping, presenting with persistent pain, then perhaps raising, you know, just checking in how they're going. People don't have to tell you their trauma story, and we shouldn't expect them to. So sometimes, you know, if I've got someone maybe that's had long-term persistent pain, I might talk to them generally and say, you know, sometimes other people I've seen in a similar position to you and their journey have been through really terrible, traumatic things. You don't have to tell me any details, but, you know, is that something you've experienced? And that will sometimes sort of open the door just to be able to work a little bit more. And there's very good services as well, like QPAST, Torture Trauma Service, World Wellness Group, and some other services as referral points. One other thing, last but not least, that we can certainly do to assist our patients is engaging interpreters, and I think all of us tonight will hammer home this point. So there's a free interpreting service, doctor's priority line. It's not appropriate to be, you know, asking family. It's not appropriate to be asking someone's children to interpret or the support worker that might come with them. So just draw your attention again. If you're not registered with TIS, please do so. You can pre-book interpreters. You can ask for a particular gender, but you can also get interpreters on demand on phone. The rest of you can use the clicker better than me. The last slide was just really some resources, but I think I'd be happy to share these slides if anyone would like them afterwards. So I just draw your attention again to the Refugee Health Practice Guide. Royal Children's Hospital Melbourne has some really good paediatric resources, and also our Refugee Health Network of Queensland website. So what we might do, that's a bit of an overview. In the interest of time, I think we'll have most questions at the end. Our next speaker I will introduce is Najma Bahia. And Najma, what's your bio? But Najma is the team leader, is that right? With Multicultural Australia, which is the settlement service in Queensland. And Najma's going to come and talk a little bit about the role of settlement and how settlement supports people on arrival, but also that interaction with health services. Najma, you do have to leave a bit early, don't you? So would you be happy to take a couple of questions at the end of your talk? Perfect, thank you.
Thank you so much for having me. I will start off by acknowledging the Agger-Turrbal. Thank you. As the traditional custodians in the land in which we are meeting on tonight, I'd like to, Multicultural Australia, we do recognise that this land has and always will be Aboriginal and Torres Strait Islander. We pay our respects to Aboriginal and Torres Strait Islander peoples, past, present and emerging, and recognise the immense cultural and linguistic strength and diversity that has existed on this land for tens of thousands. Okay, great. So essentially today, and Rachel, thank you so much for the introduction, is we will be talking about the HSP program and predominantly the role that our coordinators play in working alongside our clients or newly arrived Queenslanders. Just to give you a bit of a snapshot in Queensland at the moment, Multicultural Australia is currently supporting over 5,000 newly arrived migrants and refugees in the humanitarian settlement program. Majority of our families are being based in the Logan, Brisbane area, and of course that is, I do acknowledge the rental market crisis at the moment. And just for curiosity, these are the top 5 ethnicities that we are settling in Queensland at the moment. So we have quite a substantial amount of Afghan clients, Rohingya, Tajik, Congolese and Tigrinya. Okay. So like Rachel mentioned earlier, a journey for a newly arrived migrant and refugee, there is a number of things that clients are managing at that point of arrival. Within the HSP program, we do support clients up until 18 months, so that's that pre-arrival support and 18 months of their resettlement journey. These are some of the key components or touch points in terms of our work with clients in their resettlement. Some of the main areas that we do support with is that on arrival, that welcome for our clients, and particularly supporting them with that linkage to those essential services, so accommodation, health, education, learning English, and also employment where where required. I will touch on these key components throughout the presentation. So essentially, the HSP program focuses on supporting newly arrived migrants and refugees in their resettlement journey. And what that looks like is a case management approach and also cross-collaboration across a number of teams within Multicultural Australia. These are some of the visa subclasses that our newly arrived migrants and refugees class under. So we do have the 200 visa subclass, the in-country special humanitarian visa, which is your 201s, emergency rescue visa, 203, women at risk visa, 204, and of course our sponsorship visa pathway, which is our 202 cases. The HSP program is delivered statewide across Brisbane, Logan, Gold Coast, Toowoomba, Cairns and Townsville. And as I mentioned, a lot of that work is that cross-collaboration within case management, on-arrival support, and predominantly working on building the skills of our clients and the strengths that they bring when they do come to Australia. We do have some key foundational settlement outcomes that is the core focus of how we navigate and support our clients to connect to essential services. And that is a continual journey from the point of arrival up until their 18 months. So it's a constant educational piece that we continue to provide our clients throughout their settlement journey. And then that is also then continued after the 18 months when they are transitioned to a SETS provider. And of course, accommodation. So I think that's something that we can't lightly touch on, but accommodation is such a significant element of our newly arrived families in Australia. The most prominent component that clients do come to us with is sourcing that stable accommodation, which is sometimes probably the most significant milestone in a client's resettlement. So having a home and creating a home, which then becomes the foundation and support systems that clients can navigate more freely and confidently. Okay, so within the HSP program, there are different subclasses or levels of support. So there is Tier 2, which is low to moderate level of support, and also Tier 3, which is specialised and intensive. So that's where we have clients where there are some significant barriers in their achievement towards their settlement goals. And I will focus a little bit more on specialised and intensive towards the end of the presentation. It's important to note that every client that is referred into the HSP program is assessed on an individual basis, because we recognise that every individual has their own goals and their own settlement needs. And so it's important that whilst some clients might come as a Tier 2, originally from a referral, we understand that within the settlement journey a complexity might arise, and some family members as a result of that will be referred to Tier 3, which means we do have a mixed, approach in supporting those families. So you will have Tier 2 and Tier 3 engagement in that support. Okay, so just to give you an idea of the HSP model, in Brisbane, particularly in Logan area, we have done a bit of a restructure with our HSP program. And what we found is that clients on the previous iteration of the HSP model found that there were different needs at different periods of time within their settlement. So with that being said, we have remodeled the HSP program, still having the same levels of support, where we have more, preliminary intensive support within the 6 months, and then 6 to 18 months, we have a continuity of support in a different team. It's still within the HSP team, but there are different levels of support or different needs that we're presenting, which required more of a shift in how we deliver services. So in saying so, some of the terminology I will refer to is welcome team and also connection and belonging. This is a bit of a snapshot of where that touch point happens. So the welcome team is pre-arrival, arrival up until 6 months, and connection and belonging is the 6 to 18 months, and also supporting with that transition or graduation to a SETS provider. So within the welcome team, the role of a welcome coordinator is empowerment through education, and that really pivotal point of linkage to essential services, like I mentioned earlier, so definitely health, housing, education and employment. Within this team, you are also building on the life skills and the strengths of clients, and predominantly supporting clients with the continuity of their life skills development. So we're creating the stepping stones for them to achieve those settlement outcomes. Part of that role is the facilitation of the life skills program, which happens within the first 28 days of a client's arrival, and also the comprehensive health assessment. In addition to that is initial accommodation support. So that's through our temporary accommodation or long-term accommodation, which is a head lease model. And what that means is that Multicultural Australia becomes the owner of the property, and clients, because they're building their life skills and understanding of how to maintain a home, how to pay rent, so that concept of money might be very foreign. That then becomes the responsibility of Multicultural Australia, and so clients then work collaboratively with an accommodation officer to help them achieve that learning piece. After 6 months, they are then transitioned to a connection and belonging coordinator or connection support worker. So as you can see, the first 6 months are very busy for our clients. However, that 6 months is definitely building the tools for them to be able to start their next stage of their settlement journey. Okay, so that transition point then comes to connection and belonging. Here we really do focus on, I guess, reinforcing the skills that those clients have developed within the first 6 months of their settlement. A lot of our role in the connection and belonging team is very goal orientated, and also supporting clients to build their sense of self-efficacy and independence. The primary focus is a lot of community-based work. There still is that level of one-on-one, face-to-face service delivery. However, moving forward, what we did find is that within the 6 to 10 months, clients were presenting with particular needs. So for example, within the first 6 months in the welcome team, most clients are building their level of English and understanding health systems and navigating that on their own. At the second stage of their settlement, they're finding that they are more comfortable to engage with employment services, and more comfortable to be able to book their own appointments and liaise directly with GPs. So, which is why some of the shift in terms of how we deliver those services is required in this next stage of their settlement. So majority of the time, we're asking clients to come meet with us, whether it's at TAFE, whether it's at one of our offices. It's really trying to help promote that level of independence and helping them understand that, or feel comfortable to be able to navigate getting to the office or getting to a GP appointment on their own. So the development of tailored interventions and information sessions. So what that also looks like is we acknowledge that within the next stage, housing is a significant component for our clients, because now after 6 months, Multicultural Australia supports the client to have the tenancy be put in their name. So that way the client has now got ownership, they've got that responsibility, and then our part is to continue that life skills so that they then know how to continue to maintain the property, know how to contact the real estate agent or the property manager around maintenance concerns. So those housing information sessions are really supporting clients to build on the skills or the knowledge that they've developed in the first 6 months and help them apply more of that knowledge in this second stage. So particularly within the first 6 months in the context of health, our role is supporting clients to attend their comprehensive health assessment. And part of that role is a lot of coordination with our refugee health teams, but also our cultural support workers. So I will refer them to as CSWs, just as a point of reference. Our cultural support workers are provide in-language support to our clients and help them understand the healthcare system. And part of their role is helping them coordinate those appointments. So if we receive a referral from Refugee Health saying that this is the date of the comprehensive health assessment, a CSW is booked to remind the client about the appointment and also advise them about how they're going to support them with that appointment. Essentially what happens is that on the date of the appointment, a CSW comes to the family's home and then supports them where possible through public transport, how to get to that appointment, and also how to get back home from that appointment. It's really important to emphasise that our CSWs do not provide language support within the actual health appointment. They will wait outside and until that appointment is concluded, and then they will support the family back home. And I do encourage that you do continue to use interpreters for that very reason. The support as such is not unlimited, but we do try to make sure that there is a encouragement for our clients to be able to build their independence and comfortability to be able to attend medical appointments on their own. We do have to balance service dependency with empowering that client to be able to achieve and to be able to know how to progress without so much dependency on a service. Just some considerations. So I know Dr. Deb might come elaborate a little bit more in your presentation, but some concepts that we do want to put into play is the concept of time and urgency is something that we are trying to balance with our clients. Sometimes clients may say that they're physically well and they don't understand the need for a medical appointment, and that's an educational piece that we are navigating with our clients to help them understand the importance of a comprehensive health assessment, for example. Support with coordination of appointments. So like I mentioned earlier, our CSWs, if you have an appointment that's scheduled at 10 o'clock, our CSWs are booked in advance to help remind the client prior to the appointment and also to attend the client's home at 8 o'clock in the morning. We do give a lot of pre-planning and supports because we understand that this might be something quite foreign and new for our clients, and it helps establish the expectation. So our CSWs do try to make sure that they do go earlier to then support the client to attend that appointment. However, I do acknowledge at times, sometimes when our CSWs do go to the home, clients have forgotten. Some might be still sleeping, so it's a very quick rush to get them ready to go. And we do appreciate the patience and understanding, because I do understand how much resource and planning and support is coordinated from a GP's lens. So please bear with us as we continue to navigate and balance that conversation. If you find that a client is continuing to do that, please let us know, because we can bring in that piece of education and life skills development that will be beneficial in the long run. Yes, so coordinators work closely with the clients to empower and build their life skills, and of course encourage to attend and attempt to attend without, I guess, as strict guidance from us. So we do try to aim to support clients for their first 2 appointments. However, as I mentioned earlier, it's not limited. If we know that a client is requiring additional support, we will provide that support. Yes, families from collective cultures, as you may have already experienced, sometimes do come attend appointments together. Although the appointment is for one person, you might have the whole family coming. And that, again, is something we are trying to navigate with clients. We have found that there is that codependency, and that there is that, that comfortability of, this is my support system and I need them to be there with me. And so we are trying to explain to our clients that it's okay to have someone attend the appointment with you. You can sit outside while mum goes in to the appointment or dad goes in, and there'll be just a couple of, maybe half an hour, 40 minutes, and then they'll be back out. And so please let us know again if there is quite a constant support of a lot of people in the practice, and we can try and navigate that with you. Oh yes, and of course other considerations is digital literacy. So we are finding that that is embedded in our life skills component within the first 28 days of that life skills workshop. However, we do acknowledge that sometimes clients may not have the digital literacy, and they might rely on their children to be able to look through and explain to them some of the text messages or reminder messages that they're receiving, and that's a piece that we are working with. We do find that if clients don't have the number saved, they will not respond. And there has been quite a significant piece of information given around, IT security and making sure they're not clicking links that they're not aware of. So some role that we have played is helping clients save the number so that they know that this is an appointment, that they need to remember to RSVP or contact the practice directly. Yes, for upcoming appointments, please email our health service officer or the allocated coordinator. It helps us preempt those planning arrangements for clients. If you're finding that you're not aware of who the welcome coordinator or connection coordinator is, please reach out to us. We can definitely help navigate that. And again, if client is uncontactable, please reach out to us as well. So some of the challenges that we do see in the settlement journey, and I'm sure that you do see that in some of your presentations, is they may experience that culture shock upon arrival, and they're juggling many things and trying to understand new systems and just a new way of life. Some other components that we do acknowledge and try to support with is the acknowledgement that there is going to be language barriers, the awareness of Australian culture, distrust and fear, particularly with authority, loss of family and supports, trauma and post-PTSD. Again, just to continue, experience of violence and tragic loss, health and mental health challenges and the associated stigma that might come from mental health, change in gender roles and status with family members. This is something that we are constantly working with our families for, given some family members might be seen as the provider of the family, and that shift does sometimes cause some tension or change in the dynamic. However, we do try to make sure there's equal understanding and knowledge of what men and women can access and what services they can engage with. Overseas qualifications, that's something that we have addressed as well, is that recognition of qualifications and how coming to a new country, it's not recognised, and that, I guess, having to step back and start all over again. So some of that angst and frustration around that can also be a challenge that we do navigate in a lot of our conversations with clients. Different cultural and child raising practices, making social connections, and absolutely housing. I did want to provide a bit of an example of the robust support that was provided and is continuing to be provided for our Palestinian and Israeli nationals within the HSP program. So within the HSP program and also ASRA and SETS, there is a level of support or case management support that is being provided predominantly under the HSP program now. The support is voluntary. I do want to preface that. Clients may already be onshore, and so there is a bit of a backwards referral process where it is initiated by families that are already here, and if they would like to access HSP support, they can contact us, and we can then appeal to the department to get that referral pathway for those clients. Given it is a voluntary service, we do encourage, if you do know any families that are in Australia from Israel or Palestine and they are requiring case management support, please, and you're not sure if they're engaged with our service, please reach out to us. You can also instruct the families to come to one of our offices where they can meet with our intake team, and we can help triage and assess the need there. Some of the services that have been available are under the particular visa subclasses that they do arrive on. So you've got your 600 tourist visa, although we're not seeing many come through on a 600 visa. Majority of our Palestinian families and Israeli families come under a 449 or a 786. And as you may already be aware, there are different eligibility and sometimes limitations based on those visa subclasses. For you to be aware of, Medicare is absolutely, they're eligible for Medicare on a 449 visa and a 786. However, if for any families, which we're not seeing much of at the moment, they were still using the ED and hospital systems on a 600 visa. I will touch on now our specialist and intensive service stream. So this is what we call our Tier 3 level. Am I going okay? So the specialised and intensive support program is that additional level of support or wraparound support that clients can access depending on the complex needs and presentations. There are a number of visa subclasses that clients can be eligible for for Tier 3. And the main point to know is that clients can be here up until 5 years. As long as they're not an Australian citizen, they can access Tier 3 support. It is needs-based. It's really important that complexity can arise at different times, which is why you have that 5-year time frame. And clients can be exited from the HSP program and then re-referred into HSP as an external SIS. And I will talk through the referral pathway shortly. But just the criteria that we look for is essentially the department requests an understanding of the multiple or complex needs that a client is presenting with. And again, it's quite individualised. So disability, health needs, mental health, homelessness, domestic and family violence, child and youth welfare concerns. And sometimes you find that these factors are compounding, so it's not in isolation. I'm nearly finished, I promise. So how you can refer, as external providers, there is an external referral pathway. So there is the department website that you can access the SIS referral form, and I'm happy to share that link for anyone who is interested. Additionally, you can contact directly to the department, or if you want to talk through a case that you're not 100% sure of and you would just like to have a de-identified conversation, you're more than welcome to call Multicultural Australia and we can help talk through the support pathways for a possible Tier 3 referral. I do have to acknowledge that with the Refugee Health team, we have definitely coordinated on some of the presentations and concerns that have been addressed at some medical appointments that we may not have the full picture of. And so that advice and guidance we've been very appreciative of, because that's helped us formulate that strong case for a Tier 3 referral. And although we might recognise there is a Tier 3 need, that approval has to come from the department before we can facilitate that support. Thank you. That's all from me. Thank you. No, that's fine. That's fine. Thank you.
Sorry,
No,
jump
you're
in
right,
front of
you're
you.
right.
Thank you, Najma. I just know Najma has to leave. So did anyone have a burning question for her before she goes? No, or yes? Oh, sorry. Ali, do you have the microphone, or do you mind? Thank you. Sorry, Najma.
Thank you.
Thank you, Najma. That was to ask, is there a limit number of people after as the cutoff, like only 1,000 that can be under the suburban?
Yeah, we do put in a forecast number of arrivals that we do propose. At the moment, we haven't reached that cap yet. Yeah.
So that question was around, is there a limit to a number of arrivals that you can support? Okay. Not sure if we've got any more questions, but I just wanted to say thank you very much. And I think particularly it's really helpful to know, and in clinical practice sometimes we're very much focused on the health appointments and people coming in for those, but clearly people have a lot going on in settlement, so being mindful of that. And I think it's really helpful to know that if we're seeing people with really complex needs, we can maybe talk to Multicultural Australia and refer so that they can get Tier 3 support, which also supports their medical care and medical appointments.
Yeah, thank you so much,
Thank
Rachel.
you, Najma. Thank you. So now I know where to point for the clicker. Thank you for bearing with me. Our next speakers are from the Marta Refugee Health Advisory Group, and we have 3 speakers. We have Ali Wakefield, Faiza Abdurrahman, and Rahim Mahamadi. Yeah, they're all here. So I will just introduce them all. So Ali, first of all, Ali's been working with the Marta Refugee Health Service for 11 years and works closely with the Refugee Health Advisory Group known as the G11, a group of more than 11 now, isn't it? Oh, we are 11 refugee health consultants who are a bridge between the health system and communities. Ali also provides support to the Refugee Health Network of Queensland, and previously to working at the MARTA, worked at QPAST for 15 years. So Ali, do you want to maybe come up, because I think you're facilitating a bit of the discussion. Faiza, would you like to come up? He's originally from the Somali region of Ethiopia and speaks Somali, Amharic, Oromifa languages. I hope I pronounced that properly. Faiza has lived in Australia for over 14 years, and before coming to Australia lived in Ethiopia for nearly 18 years, where she worked as a Somali interpreter. In Australia, Faiza has studied early education, aged care, community care, worked as an interpreter, an aged care worker, a childcare worker, and in community services, and is very much involved in the Somali community and has been part of the G11 advisory group since 2023. Welcome, Faiza. And Rahim is the newest member of the G11 group, and the youngest, apparently. There you go. He arrived in Australia as a refugee from Afghanistan and is a relentless advocate for change, and is determined to impact the world around him positively. Rahim is a psychology graduate from QUT, and he utilises his lived experience and expertise with mental health to drive systemic change. And Rahim is involved in over 20 organisations via advocacy and advisory groups, and is currently working as an engagement and project lead with the MHLEPQ. Rahim, can you help me? That's the
The Mental Health Lived Experience, Peak, Queensland.
Yes, thank you, Rahim. Thank you. So, Ali, I might let you and Faiza and Rahim.
Can everybody hear me? Okay. So yes, very busy people, as you can hear. And there's 2 other G11 members here. Just like to acknowledge Sarah and Evelyn. Thank you for joining us. So I've just got a few questions really for Faiza and Rahim to kind of expand, I guess, on what we've already heard this evening. So I might start with you, Rahim. Wondering, we've heard a little bit about the refugee journey from Rachel, we've heard about the settlement journey from Najma. Just how do those experiences impact on people who are accessing healthcare in Queensland?
Thank you for that, Ellie, and thank you everyone for coming to this event. It's really nice to see so much interest in the community about providing care to refugees. So that's really nice to hear. I guess the refugee health experience or journey is, as was mentioned before, it's a very traumatizing thing, right? So oftentimes I think the main thing to think about is while you're a refugee, you're kind of in survival mode, right? If you have a pain in your stomach or a headache that really won't go away, it's like the lowest thing on your priority when you are looking for food for your family, or wondering if you'll be alive to the very next day, or escaping persecution and trauma and war. So when you have health issues within you, oftentimes you can just completely ignore, neglect, or just block it out of your mind, right? So by the time you get here to Australia, all those issues that you're on survival mode suddenly disappear. So now you're just able to relax, and then you start realizing, oh, there actually are things wrong with my body that I've just been ignoring. Um, so yeah, that's one of the main things I think.
Thank you. Did you want to add to that, Faiza?
Hi everyone, thank you for coming tonight. I just want to add, back home or in the refugee camps, they don't have a regular or someone they see every day, a GPs. So they might go to different villages to find a good GP and a doctor or a specialist. Usually there's no GPs, it's more of a doctor in hospital. And they might not see that doctor ever again. And next time they sick, that they go to a different village or different city to see another one. So there's no consistent care. Yeah, I just want to add that bit.
Thank you. I think it's really important to know that the system here around a GP who's taking care of all your care is quite new for. I've heard some stories actually that in Iraq, Sarah tells me they just get on the phone and they call their cardiologist and they knock on the door at 11 o'clock and they go straight to the specialist. So the fact that you have to go and see a GP, make an appointment, get the referral, wait a long time to see the specialist, it's very new. Rahim, are there any specific cultural, spiritual or system barriers that you've observed impacting on families arriving in Australia as a refugee getting healthcare support in Australia?
Wonderful question, Ali. I think, yeah, I have a couple of examples for each one of them. First one would be cultural, right? So you just mentioned it before, Faiza, but not everyone has a good experience of healthcare. And I think that was on one of the presentation slides before, but you can't assume everyone has a good relationship with doctors or the healthcare system from their origin country. So you can't assume that they will just trust doctors or hospitals or medical professionals or whatnot, because maybe in their home country, doctors are not known to be kind. Maybe they're just very mean to people. Maybe they traumatize people. You hear a lot of horror stories about people being forcefully treated, forcefully medicated, people who die, get their organs harvested, very, very traumatizing things. So don't assume, firstly, that everyone will have a good understanding and also faith and trust within the health system. And I know you guys are not going to do anything crazy like that, but it's just important to keep in the back of your head in regards to culture. The next thing around spirituality is a lot of people feel once they're disconnected from their home origin, like their homelands or like their people, they start feeling like, they're disconnected from their people and their land, so it starts impacting them emotionally, right? I mean, if we think about, for example, a local context with Aboriginal and Torres Strait Islanders, the importance of country and connection to your culture and your mob. So I think this model applies to people who are also refugees. They come from overseas, they're no longer connected with their families or their country of origin, so they start, internalizing these feelings, and it very quickly can manifest into physical issues for them. Then also religion. You have many religious beliefs that might be within different cultures, like for example, for certain medical conditions like cancer or mental health issues, people might assume you have like a bad curse on you or like bad karma, and so you need to pray it away or be more faithful so that these issues can be resolved. Yeah, these are just some of the things.
To add on that, like Islamically, if someone is sick, usually they don't straight away go to the doctor. They will find different ways, reading Quran on you. They will call someone who is like imam or sheikh, and then they will see if they can do something about it. It's more of a reading Quran, not doing anything with the body. So if that doesn't work, they might try and do herbal, like black seed. It's called habasoda in our language. So you will drink that one, or maybe they will massage you on your body. So there's a lot of different ways to get medicated before you see a doctor. and usually it's not straight because it's far away. The doctor is not accessible. You have to go different city or different village, or you have to travel a bit more. They will try and use different methods of self-medicating.
Thanks for that, really interesting. So I guess with that in mind, as clinicians, how can clinicians address and work with that context? What advice do you have for clinicians providing care?
I think it's been mentioned quite a lot already, but building rapport and building a sense of trust, a sense of community, a sense of expertise within you and your client, right? Again, you never know what someone has experienced before they've come to you, so don't assume anything from them. So, but universally, right, when you come from a good place in your heart, if you're kind to people, if you're nice to people, no matter what culture, no matter what country, no matter what experience they've had, you can sense that inside you, and you can feel like you can be open and honest with this person, and that they're here to treat and to help you, is I think the number one thing. And often, sometimes we get a little bit too lost in best practice and what language to use and all that other stuff. But I think if you really just tap into that human element of it within healthcare, that's really important. Then beyond that as well, just do a little bit of education, a little bit of learning about different cultures. If, like, for example, you're in a demographic area that is really high in Vietnamese people, you might want to learn a little bit about their culture and not expect them to teach you all about it. But then also, kind of hypocritical, you also just want to ask people what their experience or knowledge is about something. Like, you could just ask them, like, for example, vaccines. You could ask them, well, what do you think about vaccines? What do you know about vaccines? And just hear what they have to say. And maybe you don't have to immediately be like, oh, that's misinformation or that's incorrect. But, you have that in the back of your mind, and you can slowly start to implement some changes and change this person's views for the better. So, yeah.
I agree on what Rahim said. Yeah, just asking questions, talking to them, understanding them, and maybe they can tell you a few things that they actually do at home if you speak to them, and yeah, using the interpreters.
Final question, I think you may have already sort of covered most of it, but do you have any further advice, I guess, about what have you seen done well by health workers in Australia, and any sort of final bits of advice that you'd have?
I think any final bits of advice is, I guess, number one, just don't assume, don't have any assumptions. If you have any biases within yourself, it's important to acknowledge that, to address it, whether it be conscious or unconscious. I think it can very quickly lead into your practice and lead into the way you treat people, even if you're not sure and even if you're not aware of it. So just trying to address that within yourself. And beyond that as well, I think just trying to keep things as simple as possible for people so that they can really understand you, so that, there's already so many barriers to them, and if we use too complex medical jargon or diagnoses that are really difficult to explain, or health information that's really difficult to understand, makes it a really big barrier of trying to understand and connect with your doctor, especially if they're using an interpreter who might not be accurately interpreting what is being said.
Maybe make the information very simple, sort of a 3-point sort of, and also write it down in a sort of a note so they can show the next person that they see, and then they can talk to that person. Maybe even if they forget, the kids or the sisters or whoever lives with them can remind them. And also, I just want to say something, but I forgot. Yeah. Was there something? Oh. Yeah, like people when they come here, they've been into refugee camps for a long time. So building trust is really important. Yeah, conversating and making them feel welcomed, and they do trust you because they're going to be here for a while and they want to make that connection, which is going to be lifelong.
Thank you so much for that, Faiza and Rahim.
Yeah, I think we would have time. Thank you again for a couple of questions, and we hopefully might have some more time at the end. And I'm not sure if for people online as well, somebody is monitoring the chat. If you want to put a question, would anyone like to ask Rahim and Faiza anything? Yeah, Ali, thanks.
This is a question directed to Faiza. Hello, I'm John. I'm a nurse and teacher at TAFE. The question surrounds the idea that people that come to arrive in Australia might end up in a community of the same ethnic background. Are they tending to go to traditional healers here as well, rather than seeking primary, like a GP clinic? Rather go to a traditional healer and seek those sort of remedies?
Ali will kind of think. Thanks, Ali.
It's around tradition.
Since I've been into Australia, I haven't seen any traditional healers. It's more of an imam, sort of the masjid leader will come to home and read the Quran. There's no nothing with him. It's just more of the reading of the Quran that he coming home and reading. But there's no traditional healer that they go to, that they have a center, or no, there's none. Maybe Decca, have you? I'm putting you on the spot.
I mean, I have seen a couple of like traditional healthcare providers, or maybe not healthcare providers, I'm not really sure that the term to use, all right? So, you know, you see it every now and then, but it's definitely not something that's like formal or anything. It might be go to someone's house and it's like in the back shed, and you know, sometimes they might just give you just reassurance, and you know, placebo is a powerful thing, and if that works for someone, sure, that works for you, but I don't think it's the first line of treatment that a lot of people go through. Kind of like a supplementary thing, or like a last resort, what I see at least.
Any other questions at the moment? Could I potentially just ask you something on that, Rahim? When you say as a last resort, is that often after people have also seen GPs and traditional medical people? Oh, sorry. Sorry, I'm wondering why you think that might be, and if there's, you know, what we can sort of do to work with people around that.
Yeah, definitely. Well, I think it's very complex, and I don't want to give one broad answer to it, of course, but I think it's a pretty natural thing, right? Even, you know, people in the general community, general public, for example, if you have like a stage 4 diagnosis of cancer and it's terminal and doesn't really look like the prognosis is really well going for you, you know, a lot of people do turn to other forms of supplementary or additional medicine just to try out everything, because what's there to lose, right? And yeah, I think for people who come from multicultural backgrounds, I think it depends. Like there's a wide range of people. Maybe they might go to it as their first line. Some people might go in the middle to see if it might alleviate some symptoms. And then some people, like the general public, will just see it as like the last resort of treatment. So yeah, very complex question, but thank you.
Rahim.
Oh, Rachel, there's one more question here from Victor.
Yeah, okay. Yeah.
Thanks, Faiza and Rahim. I know one thing first that families from refugee backgrounds really struggle, migrant background more generally struggle with, is the fact that doctors have very limited time to see a patient. And you guys talked about trust. And trust and time, I think they don't go together. So what would you, knowing that we are in this forum with health practitioners, what would you really recommend from what you know from refugee families about what healthcare practitioners more generally, but mainly doctors, can do to really help build trust in migrant and refugee population?
Really good question. It's actually got me thinking a little bit. I'm a little bit stumped because I know exactly what you mean. I go to my GP, even if it's 9 a.m. in the morning, and I still have to wait an hour because apparently he's running late. Everyone else, right? But definitely a very time-poor system. You know, you have 10 to 15 minutes in a standard consultation to really connect with someone, listen to their problems, build rapport, etc., etc. I think, again, I think it just all falls back to not the amount of time you have, but how you spend that time with them. You know, if you, for example, want to learn about all their health conditions and everything that's kind of their worries at the moment, or bring up 2, 3 multiple things, you're not going to get very far with them. But if you can just make it really simple, like they came in today like a headache, and you only focus on one part of their symptoms and really try and hammer in on points like that, along with the interpreter or their carer or their family. I think that's what really matters. And I think a really important thing to note is don't expect change too suddenly. You know, the first generation of refugees, migrants, asylum seekers, they might still not trust the healthcare system after 20, 30 years in it. But that's not to say that the next generation won't take those learnings, won't see that progress and then take it in within themselves. So in regards to building trust and rapport, it's really how you would do anyone else, right? But I think, again, it's just those complexities that hold people back. And if you expect change too quickly, you're probably not going to see it.
Building relationship with the client, with the patient is really hard because you're not actually communicating with the person. There's another person who is a translator or interpreter. So the person might hold some things back, so that, especially in my community, privacy is really a big thing. So they might not say everything they wanted to say, so there's no relationship. It's just more information going back and forth. Maybe after 5 years they've been here in Australia, learn the language, and maybe then they can start building relationship with their doctors. But I don't think for the first couple of years, while they're trying to learn the language and navigate the system, they wouldn't be able to build any relationship at all.
Thank you. We might let you sit back down, perhaps if there's some questions at the end. Thank you. And I think Dr. Debs might talk a little bit to that around as well, working with interpreters and building trust. But next up, I think we've got refugee health nurses from Metro South coming up to speak to role of refugee health nurses and sorry. So I'm just going to introduce Jasmine Neal and Elle Harvey, who are both clinical nurses from the Metro South Refugee Health Service. And Jasmine's an experienced clinical nurse with a diverse background across lots of areas: aged care, disability services, public health and refugee health care. And you've worked in Southeast Asia and remotely in Queensland as well, and now with Metro South Service. And I'm losing myself, I'm so sorry. And Elle, I think your background is across many sectors as well, including emergency, is that right? And public health, and yeah. And so now you're the lead clinical nurse consultant of the Metro South Service. Yes, with acting. Thank you. So, let you come up.
Lovely, thank you so much. Thank you, Dr. Rachel and the Refugee Health Network for inviting us to come and share a little bit about what we do as refugee health nurses. And thank you again to the lovely hosts who have welcomed us into this beautiful space tonight and provided such a delicious meal for us to share together. It's been really beautiful. I would just firstly like to acknowledge the traditional custodians of the land and waters that we're meeting on this evening, as well as acknowledge the strength, resilience of the refugee, asylum seeker and called communities who now call Australia home. And I also want to acknowledge the vital role that all of you play from GPs, practice nurses, allied health, NGOs, you name it. If you're here tonight, we appreciate you and the support that you provide to refugee families. Hopefully by the end of this presentation, you'll have a little bit of a deeper understanding about the role of refugee health nurses and how we can better collaborate to provide culturally safe, person-centred care. So what do we actually do as refugee health nurses? We support clients from when they arrive in Australia and are often their first point of contact with the healthcare system, which is certainly something that we don't take lightly, and we do try to ensure that every client that comes through our door has a really positive first experience of healthcare, so that they're set up for success in the future. We start with initial triage of their referral information and those overseas health records that have already been talked about through the HAPLITE system. And we offer a phone or clinic appointment or a home visit within the first few weeks of them arriving. When it's indicated, we can also complete a comprehensive nursing assessment. We help families navigate our very complex healthcare system, build health literacy, and try to provide ongoing support for complex needs. And these might be medical, psychosocial, or social needs as well. We act as a bridge between the settlement services and the healthcare system, which is really important, especially in those first couple of weeks of arrival when everything is really new and overwhelming. So how long are we engaged? The duration of care can vary between, all of those refugee health nursing services across the state. For our team here in Logan, because of the sheer volume of referrals that we receive, we'll normally engage with a family for one appointment and then discharge to GP care. If there are some really complex needs, we can sort of continue to work with a family until they can be picked up by a longer term care coordination or nurse navigation type service. And there are, a few pathways in that regard for, called specific nurse navigation. So we've talked a little bit about those pre-arrival health checks. They are, full body checkups. However, in our experience, they can be a little bit basic. Like anything, it depends on who's filling it out and the kind of information that you're going to get. They can be outdated, so they might be from a few days before departing to Australia, or they might be from a year or two before. So they might not fully reflect, current health needs or really paint a full picture of what someone has experienced. Once clients arrive, we triage with a holistic lens. So we're looking at more than just their physical health. We might be looking at, the size of the family or their language, their ethnicity, different psychosocial factors. So trying to consider, a broad range of things when we're triaging. If urgent medical care is needed, then we can coordinate that within the first 24 to 48 hours of arrival. So that might be, someone's arriving with a medical escort, they've travelled with a doctor or a nurse on the aeroplane, and that medical professional needs to hand over to a physician here in Australia. So we can book that doctor's appointment or coordinate with, emergency departments at the hospital and let them know that this client will be arriving. We will then schedule follow-up appointments or phone reviews as needed for kind of that ongoing health education and planning. So when it's indicated, we will complete a holistic nursing assessment. This is quite comprehensive. We look at a lot of different things like the medical history, medications, we'll do cognitive screenings, functional assessments, looking at skin integrity, looking at mental health, anxiety, using tools like the PHQ-4, looking at lifestyle factors, financial distress, social factors, housing security, all of those things. And we also try and work with the families to identify client-centred goals.
So we really want to find out what is the most important thing to them at this time. And for some people that might be, managing a chronic condition like diabetes, or it may just be as simple as they want to know how to book a GP appointment. So we try and, work out what's the most important thing for the family at that time and help, work to achieve those goals. We're also assessing readiness for self-management and identifying any gaps in health literacy or any potential risks so that we can kind of safety net families upon discharge and make sure that we've completed, appropriate referrals for them. And now I'll hand over to my colleague Al, who's going to talk a little bit more about what we do and how we collaborate with primary care.
Thanks, Jazz.
No worries.
Great. Hi everyone, my name's Elle. I'm obviously one of the nurses working with Jazz. Health literacy and capacity building. For many refugees, navigating the healthcare system can be a daunting task. All health professionals need to advocate for the use of professional interpreters, as we have discussed. Effective communication is key, and professional interpreters, rather than family members or children, ensure that we're accurately addressing the client's needs. Interpreters help bridge the gap and create more effective, respectful interaction. GP engagement through appointment scheduling is also arranged. Another critical aspect is continuity of care. We recommend that our clients remain with the one GP for up to 6 months, just to ensure ongoing support and the best possible health outcomes. Beyond GPs, it's important to understand how to access various care options, whether it's visiting a pharmacy to get over-the-counter medications in case there's not a GP that's available, and to use the urgent care clinics that are available in our area as well, instead of going to EDs for some things that can be, cared for at the urgent care clinic. We also discussed calling an ambulance in an emergency, and navigating these services can be confusing for someone unfamiliar with the Australian healthcare system. Highlighting the importance of bringing your Medicare card or your healthcare card to a pharmacist, because that does provide a significant decrease in cost associated with those medicines as well. When it comes to prevention, we must never underestimate the power of immunisations. Vaccinations play a critical role in public health. Uploading IMS into the Australian immunisation record online also facilitates GPs and the practice nurses to coordinate those catch-up immunisations. Social connection through services like Settlement Services International, known as SSI, and collaboration with the Metro South Health Equity Unit and their Active and Healthy Logan program helps build social connection. These programs foster a sense of well-being and support that is often just as important as medical treatment. Preventative health measures like breast cancer screening, bowel, cervical screening, and skin cancer, as well as eye testing, is really promoted within our service, as understanding these rights is empowering for that person for preventative health care. The Australian Charter of Healthcare Rights is also explained within all Metro South facilities. That's the responsibility of every health professional. The understanding of these rights just provides the client to feel more confident and to advocate for themselves, which is what MA also encourages as well. What else? In-language resources are also very important. Depending if they are available, we will try to use them and print them out and discuss them with the clients depending on their health conditions. Now let's talk about collaboration with primary care. Refugee health nurses refer to the GPs for long-term, culturally safe care in the community. We provide background information on the client's medical and the family history, share their overseas health records through a secure messaging platform with the client's consent, and conduct health assessments, as Jazz also discussed as well. We ensure that the referral letter is clear with the clinical priorities and the patient-centred goals. This just helps the GPs to pinpoint what exactly the client is aiming to achieve from that appointment with the GP. We also work closely with the HSP providers, obviously, to support the clients with those services and appointments. And we also link with other services with QPAST, oral health, disability and aged care, carer support and long-term care coordination if there are clients that have these complex healthcare needs. Building trust, building trust and improving health literacy is a long-term commitment. For refugees, trust doesn't come overnight, as we've already discussed tonight. Past trauma, cultural differences and unfamiliarity with the healthcare system can create a real barrier to care, and we do need to recognise that this and approach clients with patience and empathy, and we do try to do that with every client we see. Strategies to build that trust can include, obviously, the use of professional interpreters, and when able, we do offer the clients to have individual one-on-one consults with the nurses, and we could obviously liaise if they want the family members there as well to offer that additional support. Other strategies include reassuring the clients of their rights and their confidentiality, so healthcare in Australia will not be impacted by their visa application. This assurance is crucial to make them feel safe and respected. Also asking open-ended questions to uncover any underlying concerns. Often there's more going on beneath the surface. And of course, keeping terminology simple, which has already been discussed as well, and really employing them to use the teach back method. In conclusion, the refugee health is a shared responsibility. It's collaborative, an effort between healthcare providers, settlement services within the community. Some key takeaways would be to think holistically, not just about their medical history, but the migration experience, the culture and the broader context, and be open to communication. Reach out to the refugee health nurses if you need any additional support. We're always there to offer our experience, and if we don't know something, we'll go and find it and let you know. And please remember that we're all working together. There may be some things that you come across that are new that we may not know, so please share all the information so then we can provide the best care that we can possibly give to our clients. Just some resources, and thank you for your time.
Thank you, Elle and Jasmine. I did have a question, but I might put it out to the floor first of all, sorry. Does anybody have any questions while Elle and Jasmine are up here? Yeah, one, thank you.
Thank you so much for your awesome presentation. As a registered nurse, I'm curious, I'll be interested in, to become a refugee nurse, does it require postgraduate study or specialised sort of?
No, there is no requirement to do a postgraduate study. It is obviously a, what would you call it, favourable if you did have any postgraduate studies in like public health, but there is no requirement. Yeah.
Thank you.
Would it be fair to say that as new, nurses that are new to this area come through, that they would receive a lot of support from, people who've worked in this area for a while, and there's a Refugee Nurses Australia?
Yeah, definitely. There are many support groups, I guess you would say, and there's also that knowledge of vicarious trauma. So you need to be able to factor in that support for yourself and your colleagues as well. And we rely heavily on our team to do debriefing to support one another through those difficult stages.
Thanks, Elle. And I think, as we mentioned before, there are refugee health nurses across the state in all of the main settlement areas. And one thing that I've really noticed from all of you is that you actually communicate with each other and support each other and share resources. And yeah, thank you. We might get you up a bit later if there's some more questions, so thank you very much. And just a reminder as well, as Elle said, if you do have any queries or want some extra support, please reach out to your local refugee health nurses. So our final speaker we've got tonight is Dr. Deborah Hillman White, Dr. Debs, as we all refer to you. And Dr. Debs is a GP that many of you know. a well-respected colleague who works at Medico Inala, which is an entirely bulk billing practice in Inala, and Deb sees lots of the new arrivals into southeast Queensland at the moment. Deb loves being part of the multicultural Inala community, as per her shirt that she's wearing tonight, and feels privileged to have the opportunity to work with a diverse patient population. And Debs is also a member of our clinical advisory group with the Refugee Health Network of Queensland. Leave it to you, Debs.
I'm the finale. I certainly hope I go out with a bang, not a whimper, and I am petrified of this ruddy, sticky thing now. Oh, I'm aiming for there. I'm a huge movie buff, and I absolutely love the Mission Impossible series. So I couldn't resist. Tom, you've had my heart for 30 plus years. So thank you very much for the opportunity to speak to you all. My name's Debs, as Rachel said, and I'm a GP working at Medico Inala. So that's one of Brisbane's last 100% bulk billing practices, where around 80 to 90% of my patients are refugees and from culturally and linguistically diverse backgrounds. The rest are from a very, very low socioeconomic demographic, and so our clinic actually has a couple of specialist clinics which feed into that. So Dr. Matt, my practice owner down here, runs all the drug cessation services with another of my colleagues, Dr. Joss, and they are the founders of the mobile outreach hepatitis C treatment clinic, otherwise known as the Combi Clinic. So I'm very proud to be part of that, and very proud to be part of the practice. I think that delivering healthcare is about trying to do, I'm so very lucky, Mr. Paragraph here, I'm so very lucky to be supported several days a week by the sensational Marta hospital team with 2 clinics. So I run the Marta Integrated Refugee Health Service program, which is for newly arrived refugees, and also I am one of the GPs working on the Multicultural Health Coordination program, otherwise known as the MHCP, which is a service for complex care patients. Look, I think that delivering healthcare is about trying to do the best you can with what you've got. Now, we're really lucky to have some unbelievably helpful clinical guidelines in refugee health, which I think, of course, are absolutely necessary. But I've found that having them as a marker of success sometimes feels like a recipe for feelings of permanent inadequacy. I think that we're all here tonight because we want to help people and to do the absolute best we can for our patients. However, I think the honest thing to say is that that's not always going to be possible. What is possible, I think, is being open-minded, thinking flexibly, and making small amendments to your practice to assist those who need it most. And that's what I'd really like to help you with tonight. Oh, great. Slide 1. Look, I think this is the slide I had to have. I think working with interpreters is always one of the things mentioned when we talk about working with refugee patients. It is absolutely the elephant. Oh, have I got the right one? Yep. It is absolutely the elephant in the room. Now, Rachel's already covered off the basics in her slides, but I have a couple of additional tips. Number 1, I think it's really helpful to document first and second languages. Most of my patients are far more talented than I am. They speak several languages, and sometimes it's not always possible to get their language with TIS. So have a second one in reserve. They'll speak it, and it usually goes much better. If you can avoid long waits, see if you can get buy-in from your practice reception. I am very, very indulged at my practice by absolutely gorgeous reception staff. They actually often call the interpreter while I'm finishing off the previous appointment. So that means I don't have waiting time to get onto the interpreter, and it actually cuts down waits and saves a lot of time. I'm going to advise no names. So I always call the interpreter, because some cultural communities, as we've already heard, I think from Faiza, they're quite small, and I've had situations where the interpreter and the patient have known each other, and that obviously flies in the face of confidentiality, so I'd advise you to keep it a little bit anonymous. I think this next one should be my personal motto: lower your expectations. Everything takes twice as long with an interpreter. Even the just one more thing at the end of the appointment where you have the back and forth with the problem that's a sneak in at the end, it can actually take up to 10 minutes. So for me, I try to dig a bit deeper, and for me, I think one appointment generally covers off one issue in a bit more depth. In terms of my actual technique when I'm on the phone with interpreters, I do try to really use plain language that's hopefully easy for the translator to translate. I say that speaking a second language myself, so things like, cerebral malignancy, for me that's a brain cancer. Hypertension is high blood pressure. I think it just makes it that little bit easier for the poor interpreter at the other end. I signpost a lot. Look, I am really sorry to say this one because sometimes I just don't have enough time to go with the back and forward kind of imparting of knowledge, and then the patient will ask a question and then it goes back and forward. And so sometimes I find that signposting works a little bit better and a more didactic approach. It's not ideal, but sometimes it's a bit more practical. So what I tend to do is do things like, I'm going to tell you about your infection now. I'm going to tell you all about it, how you've got it, how we treat it, and maybe if you could, just wait to the end for your questions and we'll go through them then. And it means that I just get a little bit more across with a better flow, and I think less kind of chaos, I would argue. So I do tend to signpost a lot. I do a lot of chunking and checking. So I now actually speak in paragraphs, I think, thanks to my work. A new subject is a new paragraph for me and something new for the translator to translate. And then that makes it easy for patients to then talk back to me so I can check their comprehension. So it's a real chunking and checking kind of approach. And the fourth thing I'd really recommend people do is to use illustrations. I love pictures, patients love pictures, just a picture is worth 1,000 words. So quite often I'll say to the translator, I'm going to show them a picture of a clot in a heart artery to explain their heart attack. And then I'll go on with what I'm about to say to the patient, but I'm pointing to the picture. And to me, it really helps explain things, and I have my computer set up so I can do that. CT versus MRI scanners, that's another common illustration that I use. So I'd really encourage people to do that. And it does mean involving the translator a bit more, I have to say, because they're not able to see what you're pointing at. So sometimes I'll say to the translator, I'm pointing at this, now I'm going to talk to the patient about what I'm pointing at. So you do sometimes have to involve the translator just a little bit more, otherwise mindful that your consultation is with the patient and not with the translator, obviously. Got my next slide? Oh. Okay, when first starting out, I had actually quite a few teething issues that made me realise that many of the barriers to providing good care to refugees are not at all clinical. They're actually logistical and administrative. So I've got a few tips here. So in response to the issue of no-shows, I actually now ring fence a few minutes at the end of every consultation to book the patient's next appointment with the interpreter. I write it down. I often use the New South Wales appointment translation tool to make, and I do that in the patient's language. And I have been told that my Bengali, Kinyarwanda and Swahili is flawless using that tool. So it's a great thing to use. And I have to say, this simple measure of booking the appointment ahead has really reduced my no-shows to rarities now. Another thing that works well to encourage engagement is to explain how you are going to help patients navigate the absolutely incomprehensible Australian healthcare system. Oh my word. In many cases, I find that people are more worried about the logistics and transport and the issues of obtaining their healthcare than they are actually about their healthcare needs. And I think it can be really helpful to have that discussion with patients and say, I am going to help you get from A to B. I'm going to show you where to get your bloods or direct you out the door, or I'm going to get my nurse to walk you around, because most of us have pathologies, except for our rural and remote colleagues, of course, quite near. So just helping with small things, it can really take the panic out of their eyes when you hand them the pathology form or whatever it might be. Now, especially within my role of seeing complex care refugees, one of the most useful conversations I have with them is about the role of the GP and limiting themselves to just one GP or at a minimum one practice. This is because I found that much of the poor care experienced by refugees isn't because they haven't got a GP, it's actually because they've got too many. Most of the time they've seen various GPs in several clinics, They've got no diagnostic clarity. They've had duplicate investigations and absolutely no consolidation of care. Often multiple referrals are in place to hospital specialists, all going back to different GPs, none of whom are following up on any of the recommendations made by the specialists. Therefore, all my patients get a little chat about the role of their GP and the importance of following up with me. I'm very proprietary with my patients, and I actually think it does work in most cases. Given that refugees actually often skip between GPs before they've obviously got to me, I'd actually argue that one of the best things you can do for a patient is actually a little bit of detective work. I have so many examples of patients in my complex care clinic especially having had unnecessary repeated investigations, with one great example of a young widow who'd come to me really, really distressed at another GP, seeing her for a first and only time and ordering an MRI plus several other investigations based off some fairly scanty history from her at a cost of nearly $700. Now, if only that GP had taken just 2 minutes to sign a consent for records transfer form, he would have received her records, including an exact diagnosis, the previous MRI that she'd had just 8 weeks before, and her specialist and recommendations for her specialist-led follow-up. Most things we see in the community are not an overt emergency, so it's very okay to actually do nothing in that first appointment and take some time to do some research between then and your next appointment, so you can get the management right, you don't duplicate, and you certainly don't have other situations like I've had, where I had a lady of childbearing age come to me 2 weeks ago, having had 4 abdominopelvic CTs within a 9-week period because she'd gone to different GPs who hadn't checked and who'd ordered yet another CT scan. I think she's about glowing now. My final piece of advice is that I always take the time to educate patients about calling an ambulance, which, as we know, saves lives, and I explain the role of an ED. I'm very clear about the difference between what a patient thinks is important and what constitutes a medical emergency. Elle, I think you'll know this very, very well. We used to work together in ED. I think a really, really important role for GPs working in this space is to prevent unnecessary ED presentations, which generally lead to long waits, patients getting very frustrated and often disengaging because the ED didn't do anything, nor should they have really, because it wasn't an emergency. So again, as part of that fostering good ongoing care and understanding where that care should take place, I really do take the time to have a talk about the role of the ED and emergencies so that I'm both safe, and if they do go to ED, it's an appropriate presentation. We've all had a little chat about this in the preceding talks, I think, but I find it is so easy to feel pressured when seeing refugee patients. They often come with multiple reports of issues. They're often very advanced issues, actually, and sometimes they're reported in a really frenzied manner. Sometimes you just don't know where to start. Is it the rectal bleed? Is it the breast lump? You know, is it the unexplained weight loss? So many red flags. Which red flag are you going for? Which one's going to lead to your medical indemnity insurance calling you up any time? So it's really quite frightening, and you find sometimes that you're firefighting multiple issues inadequately while being interrupted with even more being thrown at you. And I think that the only thing you can do, and I'm actually often interrupted while trying to do this, is break it down. Make a list, prioritise, and learn that sometimes the safest thing you can do is say, not today. But that actually can be really hard. And I'm going to hold my hand up to sometimes really feeling disheartened when I've made a Herculean effort to address a really complex need for somebody, and then looking at them and finding that they look disappointed because I haven't addressed so many other things. So it is much harder said than done. I think some issues need time and a thorough approach, and although we understand that, our patients don't. And as time goes on, I find myself explaining to patients that I will not compromise safety for convenience. And actually, it's usually really accepted very gratefully, and people then understand why I'm focusing a little bit and trying not to do everything at once. Again, I think it's about being open and communicating well. One small tip I'm going to give you that I think really works well, and I am all swear words and sparkles, I really am. There's a lot of drama here. I was meant for the stage. But I'm going to say that I make a really big, very dramatic, hands-out kind of show of showing people or patients that I've made a list of their problems on the computer. So I write them all down and I point. And it helps patients, I think, that have never had that ongoing care to trust you, and it demonstrates your commitment to them in the long term. It's kind of like a formal covenant, isn't it? I can see them sometimes when they see that I've written everything down and I've done it very diligently. I knit my brows, get some wrinkles up. I find that they often sit back in their seat. Their body language transforms, the situation diffuses, and it signals to them, I think, that you're not going anywhere. You're not going to forget about all their issues. You're committed. It will get done, just not today. And I think that's a really good point. Oh God, there's another picture of me up there. I'm not only here, but I'm up on the screen. It's scary, isn't it? Look, I'm going to say it's absolutely no use attempting fancy schmancy management plans unless you've got the basics right. And that's because otherwise you just won't deliver any healthcare at all. A few simple things that I've learnt to check with patients are, have they got a Medicare and a healthcare card? If not, get some help getting it from our beautiful colleagues at Multicultural Australia or anyone else that they might be under. Because as we know, under the Healthcare Directive, people can still access the emergency departments, GPs, good GPs like myself, and certainly the urgent care centres, but it becomes a really deeply irritating issue. You can't prescribe on your practice software. Quite often, you can't access the immunisation register without a Medicare card some of the time. It makes it a bit more difficult. And the other thing is if someone accidentally orders pathology without a Medicare card, they'll often get the patient will actually often get a bill. And for QML, which is my local provider, that can be up to about $300. Actually, they've got a cap on that. Now, my reception staff, again, are really beautiful. They know my patients. They actually automatically record healthcare card data on the practice software, which means that it auto-populates all the scripts. So that means that if a patient goes to the chemist, they invariably forget all their cards. They don't know what the dickens is going on. Most of my patients are illiterate. It means that they'll still get their script at a cut price, even if they've forgotten their healthcare card. It's really the difference between, say, paying $30 for an iron infusion, which I do, versus $8. So it's a big saving for them if they've got their healthcare card auto-populated on their scripts. My second question is usually, have you got an income? Again, it's no good me offering advice on gold standard dietary interventions and expensive pills if patients haven't got any money. Again, if they've got no Centrelink or any income coming in, again, contact their case manager or whoever's appropriate at Multicultural Australia, noting that occasionally you do have to kind of work flexibly, and occasionally I will fill in a 12-week Centrelink certificate then and there for the acute back pain that they've developed whilst I'm seeing them at that moment. So it just sort of tides them over. Thirdly, I ask them, what transport have you got? Can patients make yours, any other appointments? Has a lack of transport, for example, been the cause for their 4 missed cardiology appointments? So getting that right can sometimes make a difference, and if it's a big issue, sometimes I'll supplement my face-to-face appointments with phone appointments in the meantime to save some travel. Now, we've heard about the paucity of safe, affordable housing in Brisbane already, and boy, do I feel that. So another question I always ask up front is, have you got a safe house? Where are you living? How many thousand of you are there in that 2-bedroom bungalow? I have patients in terribly safe and crowded and unsafe conditions, and even in several cases, I've had quite a few cases of homelessness. So assessing whether a vulnerable patient is safe, I actually think trumps most other non-urgent health issues. So for me, have you got a house? Is it safe? Is one of the first questions I ask. We've mentioned about the next one, which is, can they read and write? So again, about, I would argue, 97% of my patients are illiterate. So it's no good giving them fancy written information or relying on them to understand paperwork. If they're illiterate, I have to work in other ways. I use a lot of pictures, I do a lot of drawings, and actually I have a lot of pictorial aids that I use with them. Now, ordinarily, you would think that GPs don't really get involved in all of this, but I really do think that to work well in refugee health, perhaps more than any other area, maybe excepting addiction medicine, you need to be comfortable crossing disciplinary boundaries. And there's a few more things that I'd like to say about assumptions, about which I've learned the hard way. The first is that within the context of rape being a weapon of war, I'm very careful about asking about family history and the paternity of any young children in the room. Especially with some of the people that I see from certain parts of Africa, it's sadly not unusual for several children to all be the products of rape. So ergo, they've got different biological fathers per se. So you do have to be careful about asking about family history, because that can actually be a bit of a minefield. The second assumption that I try not to make, and I try to really be careful about, is assuming that when I see a family, that it's the whole family. In actual fact, most of the families that I see are incomplete. Please be a little bit delicate about the way you ask about other children or absent family members, because most of the time, some of the older children, husband or the older adolescent children, are unaccounted for, and they're actually missing or stuck overseas somewhere indefinitely. So again, it's a really sad, but sometimes well-meaning sort of question that you ask that you get trapped in. So just be a little bit careful about assuming that the family you see in front of you is actually a complete family. I'm going to mention crowd control here, because you'll often find a crowd in your office, and I think my record has been something like 10, and I have a tiny office. Now, having a crowd is usually appropriate for mum, dad and small children if it's fairly generic. But often I find that the man attempting to enter my room is not necessarily the husband or partner of the female. In actual fact, most of the time it can actually be a cousin, an uncle or a brother. And it's really important to clarify and stop them coming in, and then discuss it with the female patient first as to who the male is that's attempting to come into the room with them. I will often insist on mums being seen alone to ensure that their care is private and dignified. This is sometimes a little hard to achieve with small children, and quite often I'll have to nag a really reluctant father out in the waiting room to babysit while wife comes in. You just can't do a cervical screen or talk about a female issue with 3 screaming kids in the room. I don't think that's appropriate. You just don't get the concentration. Kids soak things up. I don't necessarily want them knowing about their mum's pelvic rash. So I try to see mums on their own and get dad to babysit for a bit. Sometimes my nurses have to fulfil that role. God bless them. My next point is about the fact that I'm sure I don't need to remind everyone here that women's rights are interpreted differently around the world. And I'm very careful to have conversations with women about female issues and reproductive choices alone without their male partner present. I've quite a few patients that have elected to be on contraceptives without their husband or their partner's consent. And that's usually because having children can be a sign of affluence in many countries. And it sometimes can even be a symbol of adherence to religious values. So, and often I find that the males have more of a desire to demonstrate this, and that can sometimes be at odds with a woman's reproductive choices. So again, just please be sure to have those conversations with women on their own. One of my final points is going to be about the fact that I take issues with teenagers and older children coming into the consultation of their parents to act as translators, come social workers, come case managers, come carers. Again, I think this is an issue that really needs a lot of sensitivity, and it's a really tricky area because in many cases, children have been expected to fulfil the role as head of the family for a long, long time. And by denying them that role here in Australia, it can really add to their feelings of displacement and disenfranchisement. And I also find it a bit of a red flag, I will say, when a child does actually have to assume the role of carer for the parent, because to me it likely symbolises that the parent's not coping, there's something going on, they're not functional, that needs my help. I think this is a really delicate and difficult conversation and topic that needs a little bit of time, and often it needs a couple of consultations to really nut it out. But I think it's one that's really, really worth exploring to ensure that we give children the chance to be children, to go to school without worrying, and to reduce the carer burden that they've carried with them, often for years at a time. So again, just be mindful of that, and generally I try to remove children from the conversations about their parents' health. Okay. This slide is an introduction to my next few slides about affordable prescribing and affordable investigations for refugee patients, because every cent counts for these patients, it really does. So, depending on the pension, what your circumstances are, if you've got any subsidies and the odd bonus here and there, I believe it's about $750 a week. Now, in desirable Inala, rent will be around $550 for a 3-bedroom house. If you deduct a further $100 a week or so for your utilities and a few miscellaneous expenses, it means that you've really got only a couple of $100 or a couple of $100 per week left to buy medicines, clothes, anything needed for the kids at school. And that can be really difficult. I mean, we all know that a litre of milk now is about $1.55, and even a 2-kilo packet of fairly low-grade mince from Aldi or Coles is actually $20. So if you think that $100 is actually, 5 packets of mince, a spaghetti night is going to blow your budget. So just be aware of what you're dealing with, because, again, something like iron, about 100% of my patients are iron deficient. All of them need to go on iron or have an infusion with me. But you can actually save them $200 plus a year by just prescribing good old generic ferrosustain. It's got the same amount of elemental iron in it. And we often say, oh, it's just $200 a year saving. But actually, if you're on a couple of medications, it adds up over the year. So see if you can kind of have a look in your local chemist or get to know your local brands that are comparable to the more expensive brands, but will cost your patients a lot less. Ditto for your vitamin D. I don't have a patient that's not wildly vitamin D deficient. Goodness only knows what their bones are like before I DEXA scan them and do all the bits, but honestly, they've got 0 vitamin D. You can see here Ostelin vitamin D3. Again, it's exactly the same tablet as the good old Wagner brand, which I hope is not made in a factory of child slaves somewhere, but Wagner brand tends to be a low-cost brand. But you can see there, Ostelin vitamin D, the Ostelin brand is about 4 times as expensive and has fewer tablets. The Wagner D3 has 500 tablets, so that's really good. That's about a 1.5 year supply if you're on one a day. So again, every little bit helps. Now, I'm going to apologise to AstraZeneca because I'm just going to drop your share price on this. But you can see here, this is the difference, or just one of the examples of a commonly prescribed statin. So that's for your cholesterol. So the generic brand is about $50 a year less when you add it up compared to the branded AstraZeneca Crestor. Again, doesn't seem to make much a difference, but most of these patients that are on a statin will usually be intermediate to high cardiovascular risk, and they'll be on multiple other medications. So it does add up, and it can really make a difference just by prescribing generic brands versus the branded products. Oh. Now, I'm a very frustrated pharmacist. I'm not a pharmacist, by the way, so apologies to anyone that thinks I've taken a liberty there. But I spend hours and hours and hours and hours talking to my patients about medications, because in my experience, most treatment failures are due to medications non-compliance via misunderstanding of doses, the duration of therapy, timings. I see so many Coles shopping bags full of wasted medications. I think it's a pharmaceutical crime. It really is. It's a waste of money, and so often medicines are mismanaged in this community. My preference is actually for Webster packs, which ensure that patients get ongoing supply of their medications. Quite often the pharmacy will come and just drop me a notice that a script is needed to ensure that a patient has a continued supply, no interruptions. And in actual fact, they're cost-free in most pharmacies. And certainly if you go in and do a little bit of begging and say, look, my patient's a refugee, would you mind? Most of the big pharmacy chains will often do it on compassionate grounds, cost-free for the packing and everything else. So it's really worthwhile sometimes, if you're getting a bit of resistance from your pharmacist, just having a gentle word to them and looking really sad. Otherwise, I have a huge number of materials that I've made, which I think work really well for especially my illiterate patients. And you can see here, oh, that's a little example of one of my medication sheet. You can see here I describe it to them. It's got a little sun coming up for the morning, one at midday, and then the moon for night. I go through that with them, and then I basically do little circles and stars on it, and I usually put corresponding circles and stars on their medication packet. So, and then I get them to have a look at the writing, so they get to know what the brand looks like. And I find that that works really, really well. Otherwise, there are online aids like Easy Dose, and you can see a little picture of that one up there. But I actually find it a bit time consuming, and I am too bone-ass lazy to learn the colours of different tablets. So I don't tend to use Easy Dose. You can see it asks for a little section there on what colour the patient's pill is. But certainly if you find it easier, or you've got a little template that you use, it's certainly worth a try. And I do find really formalising medications a huge boon for a patient's healthcare. So how do I reduce other costs for my patients? Quite simply and in summary, I usually have to refer, noting that I am yet to have a referral rejected where I have clearly explained that my patient is a refugee and that I'm referring due to poor financial circumstances. Most people in hospital departments, you name it, wherever, they're really understanding of this, and most people really genuinely want to help my patient population, and for that I'm truly grateful. So normally just by explaining that that has to be the way, I manage to get whatever I need. Now for MRIs, it's one of my pet peeves, it really is. I'm going to say controversially that I do not order non-emergent or non-GP rebatable MRIs in the community. My argument is that very rarely do they change good short to medium term multimodal musculoskeletal pain management, and if they are needed, then we're into territory where I think a specialist opinion at your local public hospital is normally needed. And most of the time, actually, if you go back and look through the records, the orthopods won't do an MRI. In actual fact, dare I say, they do a lot of things clinically or work with CTs, because MRIs are obviously a priority thing to order in the department. Similarly, radiologically guided investigations in the community will generally always incur a cost. And again, I generally have to refer to the public hospital for those. So for example, if you're sampling a thyroid nodule of some kind, in my local area, it's actually an initial cost of about $600 to the patient. They get $300 back with Medicare, and then the out-of-pocket's about $300. So that's actually really, really expensive for somebody, especially if there's a couple of things to sample. So again, I normally refer in to the appropriate specialist team in the public hospital, and they'll do it for me, and they do a beautiful job, and they're really understanding of that. Second to last, and again, this isn't the ideal, I tend to refer early to my local antenatal team for pregnant ladies, and I request that the team facilitates all the ultrasounds for me. And so that's the first trimester screen and the 20-week morphology scan. So around where I am, they actually have an out-of-pocket of about $160 to $200. It's not ideal, I'm going to say that, and I do appreciate that it places a burden on our specialist colleagues, but it does mean that my pregnant patients get an ultrasound as per the antenatal schedule, which often doesn't happen if somehow they've presented late or somehow there's been a misunderstanding and they've gone to get one in the community. More often than not, they turn up to the radiology suite, ready to get their ultrasound, they discover that it comes at a cost and they walk away. So in actual fact, the benefits of getting it and maybe antagonising my beautiful antenatal colleagues far outweigh the risks of a patient that may be high risk that we just don't know about not getting their ultrasound. I'd really urge everybody to check with their local antenatal teams to see if they'll come to the party on that. I actually have an agreement with my local antenatal teams, and their reply to me when I asked them all this was, yes, absolutely happy to do it, but can you just make sure that you refer in a bit earlier than you otherwise would? That gives us time to mobilise and, for example, order the combined first trimester screen and the ultrasound that goes with that. So again, I'd really ask you to reach out and advise you to do so to see whether you can get your ultrasounds done by your local public antenatal team for pregnant ladies. And finally, I'm going to say that as we all know, there are just some things in your local community that are not cost-free. So one of those, I think a big one for me is audiology. I often have patients come that have hearing impairments, especially some of the older patients. And so again, for that service, I actually have to refer into my local team. and I get these beautiful audiology reports back. I've never had a complaint, and quite often I'll get a call where they've, explained a little tidbit of the report that I'm too silly to understand. So again, just by explaining it, I find most hospital services will come to the party and help me out with those cases where I can't get an investigation or something done in the community because of cost. So this final slide represents my personal views, and again I want to acknowledge that everybody here works a little differently. But to me, the really complex psychosocial interplay, intertwined with past trauma, cultural considerations and genuinely significant deprivation, means that actually medicine plays a much smaller role in delivering healthcare to refugees than many other specialist populations. Quite simply, my patients need more than me. They need comprehensive, multimodal, culturally sensitive management plans comprising allied health, social interventions, connection with community, medications and specialist care, not to mention care coordination and really intense and practical surveillance to ensure that they actually are able to connect with some of the amazing services that we have in Australia. I just simply can't do that on my own. I am just not sufficiently talented to be the physiotherapist, come social worker, come caseworker, come psychologist, come housing officer, come audiologist, come interventional radiologist, come nurse, come Centrelink help desk manager, and all of the above that they require. For me, working in this area has led to the revelation that good holistic healthcare is only possible when delivered by a team. The way that I've done this over the past couple of years has been I've really taken the time to reach out to people, to build professional and personal connections, network, and ask a lot of silly questions. By doing this, I have found a multitude of people and organisations that do amazing work for my patients and who do so on a cost-free basis with a translator and who know the importance of reporting back to me so that I can follow up with my patients to ensure good continuity of care and follow-up. Examples of this are my local radiology providers, all of whom know me as the refugee doctor, and they often conduct investigations on compassionate grounds for my patients, cost-free, even the ones that cost. My local QML pathology service, they go above and beyond their remit because they understand that it's no simple thing for a patient to come back again for a blood test, even if their incompetent GP has cocked up the form. They come around, they'll often ring me, we get it sorted then and there with a vulnerable patient that might otherwise miss a blood test that I've cocked up. My local optometrist, dietitian, podiatrist and physiotherapist, they send written reports back to me with explicit instructions and next steps for referral so that I can treat my patients in the community according to best practice standards. The Multicultural Australia team, who must surely have me at the top of their blacklist, I think have to have a mention from me. Not a day goes by where I'm not emailing them or calling them for help in facilitating a patient appointment, helping with money, a healthcare card, or being a key part of a comprehensive support program for a difficult patient. They sit with me and work side by side. And I'd be absolutely remiss if I didn't mention the not to be understated involvement in pretty much all of my patients of the GPLO teams at Marta, Metro South and Westmoreton and Ipswich. Beautiful Lisa is here from Metro South here tonight. Lisa, I just couldn't do this without you. I call myself a super user and I'm trying to think of new words every day to say thank you to them for the care of my patients. It comprises everything from scrounging around for missing outpatient clinic letters that tell me what's happened in my patient's appointment, to stopping my illiterate, non-English speaking patient being contacted by text. And I haven't even mentioned the angelic work of colleagues at places like QPAST, the World Wellness Group, Amparo, the Benevolent Society, Carers Queensland, Kyabra, my local intensive English language school, Milpera, who are every much a part of my patients' care as I am. Now, yes, of course, you'll need to get your fancy medical and nursing hats on for complex heart failure or cancer. But I'd argue that no matter what the diagnosis any of my patients may have, the best treatment plans comprise a constellation of measures that are best delivered via a coordinated care group, a a coordinated group. A cancer patient missing repeated appointments due to money, transport, deconditioning, or any other banal reason is simply not going to get the care they need, no matter how leading edge or technologically advanced it is. To me, it takes a village to care for these people, and I really welcome the involvement of all of you here tonight that help me with my patients. It simply makes me a half-decent GP. I'm going to finish now by thanking you all very much for listening. I absolutely love to learn, so please let me know about your thoughts and practice. I think the more we talk, the more we share, and the greater the knowledge we disseminate. I really do. Feel free to drop in at Medico and Ala. This is my room here. I like to think it's a nice, welcoming space. It's not very threatening at all. And if you're lucky, I'm going to fire up my bubble machine for you. If anyone has any ideas for future education events, I know we'd certainly love to hear of them. I have to put a point in here and say that if I've harassed anyone here in the audience with a phone call or repeated emails, I am going to point out that I think there's some CCTV here, so please don't hate me. And I really want to say thanks a trillion for listening. Please come up and see me after. I'd love to meet you all and say thank you to you all personally, but I think the better we work together, the better the outcome for patients. I really do. Thank you. Thank you. Oh.
Is that okay?
Yeah, no, absolutely.
There might be a question or two.
About my bubble machine?
I'm a bit jealous of that bubble machine.
The bubble machine rocks.
That one.
Critical part of my care.
I think Debs really speaks to that collaborative care, and especially when you talk about it takes a village. And I think as well, Rahim made some points before, it might have been you, Faiza, around the concept of the GP and somewhere being in there for that long haul. So I really like the way you show people that you're there for them and write the list and that you're there for that long haul.
The bitter end.
Does anyone in the last few minutes that we have question? We've got one question from your colleague.
First off, Deb, outstanding speech. We're very lucky to have you at Medico and Ala, Australia's #1 practice. Your altruism is inspiring, and your passion for your patients gives me goosebumps. But what I really want to ask is, I understand that you only work 4 days a week and that 1 day a week Dr. Tom Dover, world's greatest endocrinologist, comes and has to use your room. How does he feel about sitting in the Pixie Wonderland on a Friday?
Can I just say, so this is Matt's my practice owner and my beautiful colleague. So I do have an endocrinologist that uses my office, and he does get lots of comments. I think he does remove a few of the pink items, but otherwise he's learned to embrace his maleness and not be threatened, Matt.
Any other questions before we finish up, or for any of the panelists? I think Debs, in interest of time, you're happy to stay, but we'll all stay back for a little bit if anyone wants to come and grab us. But I'd just like to wrap up and thank you all for coming, and thank you to everyone online as well. It's been lovely to see you all again for another education event. Oh, sorry, yes. And just as a reminder, we do have an evaluation. Do I need to? Sorry. And I am pointing in the right direction. That one? So people can scan that one for an evaluation of tonight. And if you're online as well, it'd be wonderful if you could do that. And I'd just like to say as well, like Deb said, if you've got any ideas for further education or any thoughts about, things you'd really love to hear or speakers, please reach out to us at the network. And so we will have another education event towards the end of this year. I think we're aiming for October, so plenty of time.
I just wanted to say a big thank you to Dr. Rachel Claydon for her emceeing tonight. I think it was a wonderful event. Thank you.